So it actually started many years ago when I was a junior faculty, and the faculty in medicinal chemistry called and said, would I do physical exams on the digoxin project? And I remember thinking to myself, I should be doing my research on scanning electron microscopy and lipid absorption, but we are here at the university to help one another, and so I said yes. And it's a good thing that I did, because they were actually studying a probiotic, non-pathogenic yeast, Saccharomyces boulardii, on digoxin metabolism, but they then started looking at it in hamsters with C. difficile and found that it was effective. So I was the natural person that they turned to as a colleague. And we worked together for about 14 years with this small French drug company, looking at this probiotic back in the days when nobody even knew what a probiotic was. Not many people did, and found that it decreased antibiotic-associated diarrhea, and that it had some effect in decreasing recurrent C. diff. But in those days, there wasn't that much C. diff. In about the year 2000, we started to see a huge epidemic of C. diff because of the emergence, in part, of a hypervirulent strain that was causing much more severe disease. More people were being hospitalized, more were going to surgery, more patients were dying. And that epidemic has really continued over the last 15 years. And when you have that much more C. diff, you have that much more recurrent C. diff. And that was what led to my interest, that probiotic for recurrent C. diff. That ultimately led to me to start doing stool transplants in 2004, because a probiotic didn't work well enough to cure the patients, and the stool transplant miraculously did. Yeah, so chronic diarrhea is a real clinical challenge, because I think the tendency in primary care is to order stool cultures, maybe try a lactose-free diet, and then if those don't work, people aren't really quite sure where to go. So I like to classify it as is either guaiac positive, heme positive, or actually bloody, so bloody diarrhea, or fat malabsorption. And if it's neither of those two, then it's watery diarrhea, and that's the biggest clinical challenge. So if it's bloody diarrhea, it's almost always something in the colon, usually inflammatory bowel disease, occasionally a chronic infection, maybe ischemia or radiation. And so the workup there, usually you end up doing a colonoscopy and biopsy, and you end up making that diagnosis. If it's fat malabsorption, the two most common causes are a mucosal disease where you're not absorbing the fat, and that would be celiac disease most commonly, or Crohn's disease. Or there's not enough digestion in the lumen because there's not enough enzymes or bile acids, and so that would be chronic pancreatitis. And the workup of that is pretty straightforward too, with upper endoscopies and biopsies and evaluation of the pancreas. But if it's neither of those two and it's chronic watery diarrhea, that's the biggest challenge, and that's I think where we really need to have a more stepwise approach of where to go. And so I start by first I start by taking a history and looking for clues there. Have they traveled to some high-risk area and gotten an infection and have a post-infectious IBS? Do they have diabetes? Because a lot of people with diabetes get diarrhea from their medications or from neuropathy. Is there a family history of celiac disease or IBD or colon cancer, which might lead me to look at those diagnoses? And in terms of the second thing that I look at in my history is I look very carefully at the medications and also at the diet. Most people have already figured out if they're lactose intolerant. They really don't need a gastroenterologist to tell them that dairy products make them gassy and bloaty and give them diarrhea. But they might not have realized that fructose or sorbitol or chewing 5 packs of sugarless gum a day might be causing their diarrhea. In terms of blood work, I always look to rule out celiac disease and look to see if there's any problem with the thyroid. So I do a thyroid screen. And then the other thing I do is an inflammatory marker, a blood inflammatory marker. And a recent meta-analysis suggested that a CRP is a much better test than an ESR. So that C-reactive protein is a better screen than SED-rate. So just in the last few months, as a result of that paper, I've stopped ordering the SED-rate and I just order the CRP.
Why is it better?
They just looked at all of the studies looking at how could you differentiate inflammatory bowel disease, which is a real organic disease with inflammation, from irritable bowel syndrome, which is a syndrome in which there is no actual inflammation. So they just analyzed the data from all of these other studies, and the CRP was very sensitive. If it was normal, it was not going to be IBD. The SED rate wasn't particularly helpful there. Well, I see a lot of IBS. And especially because I'm doing stool transplants, people are coming to me thinking I'll do a stool transplant for IBS, which I always tell them before they even make the visit that I won't be doing that. But they still come, thinking that they can talk me into doing a stool transplant for IBS, which is not indicated at this time. Many more women have IBS than men, but I do see a fair number of men with IBS, and their symptoms are harder to treat, which is interesting because it's not so common.